All right. Okay, good evening, everyone. Are you able to see my screen?
Yes, I can see it.
All right, thank you. So, welcome everyone to the winners meeting on the first day of the month, the 1st of January 2022. So, my screen is not moving. Sorry. I think my screen is stuck now. Let me try to move it. Can anyone see my next slide?
Only winners meeting.
Oh, it's okay. I think it's moving now. All right. So my topic is on pregnancy of a known location. Everyone can hear me now? Huh?
Yes.
Okay, so just give a brief outline of what I'll talk about tonight. Hopefully I'll make it short and a bit precise. So I'll just do a bit of an introduction on what's pregnancy of a known location, talk a bit on the incidences, why we need to discuss it more frequently, the management, and then go on to the role of laparoscopy pertaining to the pregnancy of a known location. So basically, by definition, pregnancy of a known location is when somebody has got a positive pregnancy test, but cannot be confirmed on ultrasound scan, particularly the transvaginal scan. That's when we call it a pregnancy of a known location. But this is just basically a classification, not a diagnosis. That means further tests and follow-ups are actually required. The incidence of this pregnancy of a known location depends with locations. For centers that have got early assessment units, the incidence can be as high as 42%. And then for other areas, it can be as low as 8%. And then the other figures that I quoted were even as low as 1% in terms of incidence. So it does vary with locations. But however, in most of these cases where a classification of pregnancy of a known location is given, in up to 90% of the cases, they'll usually have a confirmed location. So when it comes to pregnancy of a known location, there are actually two relevant points that we need to make a specific diagnosis of localizing the pregnancy. And then the next thing is the management. So the differential for pregnancy of a known location, because we'll be having a positive pregnancy test or a positive beta HCG, could be pregnancy related, which is our intrauterine pregnancy, which is either viable or non-viable. You could also be having a failed pregnancy of a known location. That's basically more of a miscarrying pregnancy. Then you also have what ectopic pregnancy. Then there's the persistent pregnancy of a known location, where the beta HCG remains positive but cannot be localized. Then you can also have positive pregnancy tests or positive beta HCG as a result of other placental trophoblastic tumors or germ cell tumors. But the final outcomes, most of these pregnancies, they end up being failed pregnancy of a known location, which accounts for up to 70%. And then the intrauterine pregnancies account for 17 to 41%. But as much as the ectopic pregnancies carry a lower percentage in terms of outcome, they then become the most important as they carry a higher morbidity if they are missed. So on diagnosis of this pregnancy of a known location, the argument is always on the need to rationalize the management of this pregnancy of a known location so that a few ectopic pregnancies are actually missed, while it's also avoiding unnecessary and costly follow-up on those with the remaining pregnancies of a known location. That's the remaining 85% whom the pregnancies can always be managed well. So a diagnosis of this to follow up on this classification to end up with a diagnosis, there are actually several management protocols. Some have been adopted, some are still being studied, and some have actually been set aside. But most of them, they actually make use of the serum biomarkers and the imaging modalities. The imaging can be direct vision or can actually be by use of the sonography. So for the biomarkers, I'll just rush through where people have used the serum progesterone. Different values have also been used, but generally an acceptable level where a serum progesterone level of less than 10 nanomoles per liter is associated with a failing pregnancy. and specificity and sensitivity actually increases as the serum progesterone levels actually come down. Some actually say when a serum progesterone is less than 4 or less than 2, you're almost certain that this is a failing pregnancy of unknown location. That's why there's always a controversy in the threshold selection, but this is actually a good predictor of pregnancy viability, though it will not help in pregnancy location. Then the next biomarker is the serum HCG, the serum beta HCG. It can be used in different various methods. The first one where people use what they call the discriminatory zones, which is actually the most common, not the most common, but it's mainly used in different areas where if you do a single serum beta HCG, a single level, depending on centers of above between 1,000 to 2004 to 1,000 and 2,400 international units per liter may signify or you're supposed to diagnose or you're supposed to pick up a gestational sac if a transvaginal scan is being done. If it's not a transvaginal and maybe a transabdominal, then you need slightly higher levels of the serum beta HCG. Then actually you'd find that it's very rare for those with serum beta HCG levels less than 1,000 to have complications, but up to 50% of ruptured ectopics have been found for those with beta HCG less than 1,000 international units. Then also others have used certain distinguishing threshold values. Like for example, if it's above 390 international units, you're supposed to pick a gestational sac. Above 1,100, maybe a yolk sac, and above 1,400, you're supposed to pick an embryo. But these are user dependent and center dependent. Then the next thing where you can use your beta HCG is also when you're using the beta HCG ratio, where there is the initial beta HCG measured and then it's followed up 48 hours later. And then when you use this ratio, you actually dividing the 48-hour value divided by the initial so that you come up with a percentage. So when you then have a drop of more than 13% or a ratio less than 0.87, that's most probably going to fall up on a failed pregnancy of unknown location. Then a doubling value or a value which is more than 1.66 will probably give you either an intrauterine pregnancy or viable pregnancy. Then the value in between, that's between a drop of less than 13% or an increase which is less than 66% is more likely to predict your ectopic or your persistent pregnancy of unknown location. That's basically as far as diagnosis and classification is concerned. I'll just go through to the management protocols for those where you would have been following up your pregnancy of unknown location. So it should be actually be more of a systematic approach, but having the back of the mind of a possibility of an ectopic pregnancy. Then also need to be more vigilant and avoid interruption or mistreatment of an intrauterine pregnancy, which is either viable or non-viable. And then you also need to do your diagnosis appropriately so that you also don't miss the more important and high morbidity ectopic pregnancy. So this is just a protocol which has been followed up by different centers where if you've got a pregnancy of unknown location or a positive PrEG test, you start by doing your transvaginal scan. You classify, is there pain or no pain? If there's pain, you need to manage your patients as inpatient. If there's no pain, you can manage them as outpatients on an expected management, but then you do your serum beta HCG levels together with your serum progesterone, and then different values or different figures will then show you which pathway and which route to follow up. This is also basically the same protocols that are used by different. And then some other methods that have been used to follow up on this pregnancy of unknown location, besides the biomarkers, is some centers have adopted the scoring system. One example is the Bernard risk scoring system, where women are actually scored. Initially, they are triaged and they are put up into various risk groups, where you're looking at those with extremes of age, either below 18 or those that are above 38 who carries high risk of ectopic pregnancy, those who have had prior ectopic pregnancies, depending on those that have got two previous ectopic pregnancies going forward, and also those patients that are also bleeding. And these patients are actually given different scores. Like a bleeding patient is actually given a score of 4. And then on an previous ectopic pregnancy, if you've had 1 previous ectopic, you're given a score of 2, and more than 2 previous, you're given a score of 3. And then if you've carried a prior miscarriage or a beta HCG above 2000, you're also given a score of 1. And then these patients are actually risk scored, where somebody who scores for a value of, for prior miscarriage, you're given, where the beta HCG is above 2000, you're given a score of -1. So for the risk scoring, where somebody has got a low risk, which is ranging from -2, -1, because they don't have these risk factors, they can actually be managed under surveillance and be sent home. Those that are given immediate risk are those that have got 0 to 4 in terms of the score. These ones, they are monitored, and then you repeat the beta HCG in 2 days. That is 48 hours, so that you follow them. The high risk, they have to be admitted and do active intervention, including evacuation, need for surgery if it's there, including our laparoscopy, depending on the clinical status of these patients. And this scoring system has been shown to actually have more than 90% specificity. Others have also used mathematical prediction models. One of the models which is being used in some centers is the M4 model, which uses logistic regression based on the initial beta HCG and then the HCG ratio and its variables. There's also the M6 model, which is coming in and also being used in some centers, where it's a 2-step, and then they use or utilize both the serum progesterone and the beta HCG. Then from those values, then they enter them into a logistic regression-based model. And this one has been shown to actually carry a very high negative predictive value of up to 98.6 and a sensitivity of 92%. Then the other biomarkers that have been used, and some of them, they're actually still under investigations, like where you pick for the creatine kinase, the vascular endothelial growth factors are positive markers for fallopian tubes. So where those ones have got positive, the chances are higher that the pregnancy is still in the fallopian tube. You can also use the activin B, the leukemia inhibiting factor, as a positive predictor for the pregnancy being present as intrauterine. Some use also the beta HCG, the pregnancy associated plasma protein, the alpha fetoprotein, just to show the presence of the embryo or the trophoblast. Then progestogens and the estradiol and relaxin can be used to show for the presence of the corpus luteum. Then there are also inflammatory markers, but these ones are actually a bit non-specific, as they just indicate peritoneal irritation, such as the CA125, the interleukins, and the tumor necrosis factor. Then for those that use imaging modalities to identify the pregnancy of unknown location, the most commonly used is the use of the ultrasound scan, specifically the transvaginal scan, where people are actually looking at the endometrial thickness in patients, and can also be combined with the beta HCG to come up with the discriminatory levels, as I've mentioned earlier on. Some also look at the endometrial thickness, where if it's below 8 millimeters, it's associated with an abnormal pregnancy. And then they also look at the presence or absence of an adnexal mass and intrauterine fluids. Some also look for different signs to pick up the position of the embryo, either it's intrauterine or extrauterine. Then the management guide is also based on how stable the patient is. As pregnancy of unknown location should actually be managed expectantly most of the times until the final outcome is determined. But if the patient is unstable, then there's need for more active intervention. And then there should actually be clear written information and advice to the women, those that are going to be managed expectantly, so that they can be followed up until a final diagnosis is made. And then the ectopic pregnancy still accounts for the highest rate of the maternal deaths related to the early pregnancy if these ones are missed. So that's why we still need to follow up and be more vigilant when we see a pregnancy of unknown location. Then just coming to laparoscopy, where does laparoscopy come in as far as pregnancy of unknown location is concerned. Number one row is when you're looking at the in diagnosis of this pregnancy of unknown location. Then number two, we also have the role of laparoscope when it comes to the management of these pregnancies of unknown location. So in diagnosis, where does it come in? It actually comes in under the direct vision. Like for your diagnosis, it can either be by the use of the biomarkers or by visualization, which is either by use of imaging modalities, your ultrasound scan. Further to it, you can actually make use of direct visual confirmation by the use of the laparoscopy. So if a pregnancy of unknown location is suspected, laparoscopy can actually be used to try and localize and diagnose. However, you really, since laparoscopy actually involves a lot of things, it's surgery, it's time, and also comes with its own morbidities, you really need to have then to introduce laparoscopy where there's very high suspicion of an ectopic implantation or where immediate diagnosis is necessary, especially in the unstable patients. The advantage of using laparoscopy during diagnosis is that it does then give you the opportunity for simultaneous treatment once location is confirmed, but it does come with those risks of the fact that it's surgery, and also has got other risk factors pertaining to the surgery, including the general anesthesia. Then in terms of management, following up from diagnosis, once the diagnosis is made, then laparoscopy can actually be used for the surgical management of this pregnancy and unknown location, particularly where you've got your ectopic. So a salpingectomy or a salpingostomy can actually be done. Then also, not specifically only laparoscopy, you can also look into minimally invasive surgery for those then that have got confirmed intrauterine pregnancy, but they're actually non-viable. There is also role for direct evacuation of these products of conception by the use of hysteroscope. Thank you. I think I finished my presentation.
Oh, you have finished. Thank you very much for a nice presentation. Any comments? Any comments? Yeah.
Thank you so much, Robert, for the nice presentation on the pregnancy of unknown location. If you can just go back to your slide on the Banner score. How do you get a score of -2 or even -1 when you combine those parameters? I was just wondering when I was looking at it.
Oh, this one. Oh, yeah. I think this one now you're looking at, I think I just left some other risk factors, but you're looking at somebody like on your risk factors where you're looking at extremes of age. Somebody who is below 18 years scores 1, and somebody above 38 scores +3. And then in between 18 and 38, that's where there is I think there's the 18 to 25 who scores -1. Then the 25 to 30 scores 25 to 38, 25 to 35 scores 0. Then if you look at the history of prior miscarriage, they're actually scoring -1. And then somebody with a beta HCG of more than 2000, they are scoring -1 because they're looking at the discriminatory level zone. So if they're above 2000, where you've got a very good sonographer, you're supposed to pick, you're supposed to localize your pregnancy using the transvaginal scan.
Okay, that makes sense. Then if you say there are some of the scores that have not been included in this presentation, right? Then my next question is on doing a hysteroscopy in a patient with a pregnancy of unknown location. Because we realize actually you may find that some of, okay, you can say even up to 30 to 50% of this patient may actually have a viable pregnancy. That may be confirmed maybe in 2 weeks or so after the initial examination. So if you do a hysteroscopy in such a patient, isn't this going to risk a loss of this pregnancy?
Thank you. Yes, I do agree with you. But like what I mentioned earlier on, where I'm saying role of hysteroscopy in management of these patients, now you're looking at individualizing the clinical status of this patient. Are they clinically stable or not? You've got those patients that are so eager to localize the pregnancy so that you institute your management. That's number one. Then number two, hysteroscopy, its main role in this pregnancy of unknown location is usually mainly on management. As you can see, I spoke about a diagnosis and then management. So hysteroscopy, its major role is actually during the management, where you have localized your pregnancy. You now know where it is. And then you've got this non-viable pregnancy, like your incomplete miscarriages. Then you can actually use your hysteroscopy in terms of management, not in diagnosis of this pregnancy of unknown locations.
What would be the benefit of doing a hysteroscopy instead of MVA or DNC?
Technology.
All right, thank you, Doc. Thank you so much.
But also, I think there was a meeting last week where they are saying we should also be getting away from these blind procedures, your MVA and your DNC, where people are now moving into direct visualization of management of this condition. So by doing a hysteroscopy, you're going to be sure that you have evacuated all your retained products, and you also get to diagnose other conditions, your polyps and your fibroids, and then manage them at the same time again.
Yeah, so that's an advantage, yes. All right, thank you. Sorry, before I hand over the mic to the others, how easy is it to diagnose an abdominal pregnancy with the laparoscopy?
That one, I think I have I'll answer a bit and then pass it also to those that are doing more of these laparoscopies. As you know, in Bulawayo, it's not that very popular, so we don't get to do lots of these laparoscopies. So personal experience, I will not comment, but from literature, for those that have some pregnancy of unknown location, they can pick especially the tubal pregnancy and even the cesarean section scar pregnancy or other pregnancies that are ectopic. The pickup rate from literature, I think they were talking of pickup of more than 50%.
All right, thank you, Doc.
Any further questions or comments? Robert, Karisai.
All right. Thank you, Dr. Nyajena, for the presentation on pregnancy of unknown location. Yeah, a very difficult diagnosis most of the times, and leaves both the doctor and the patient very anxious. So I just wanted to ask if maybe I could have just missed it as part of your management, if there's any role for the use of drugs like methotrexate.
Oh, yes. All right. So, yeah, I think I was just trying to make my presentation short. You'd actually see in the management of pregnancy of unknown location, there's actually number one, the expectant management, where for those that have got failing pregnancies, you can just observe them and let them go, like your low risk. And then in terms of management, you actually have got your surgical management and then your medical management. Your medical management, that's when you talk of your chemotherapy. There's actually where you talk of single dose regimen and where they talk of multiple dose regimen, depending on how the patient is performing. Number one, you're looking at are they clinically stable? For those that are clinically stable and those that have got failing beta HCG, different centers use actually different values. Mainly for those that have got beta HCG above 5,000 and are stable, and they've got a failing, or if they've got falling beta HCG, you can actually use medical management, your methotrexate, either as a single dose or as a double, or as a two-step dose, where you give the initial dose and then you follow it up a week later, and then you then follow your routine beta HCG values. And then those with persistent pregnancy of unknown location and slightly or higher beta HCG values above the 5,000, depending on different centers, you can actually, there's actually a role where you can actually give the multi-dose regimen, either use your IMAC regimen or they use the BEP regimen. That's your etoposide, methotrexate, adriamycin, your cisplatin and your oncovin. To follow up on those persistent pregnancy of unknown location as part of the management, part of the medical management.
Thank you, Robert. I have just two comments, which I want, two comments or questions. In your reading, did you come across how you manage heterotopic cases where you suspect, well, you may not be suspecting, but you don't know the location of the pregnancy, but it could be intrauterine and extrauterine. And then my other question is, how do you actually, what precautions do you take to do a laparoscopy in a case where you suspect that it could be you don't know the location of the pregnancy? How do you do the laparoscopy?
About cases. I don't know if I will answer them well, but I'll just attempt to respond to your question. Number one, for the heterotopic pregnancy, I think the first thing is, once you then have got your confirmed heterotopic pregnancy, you're also looking on the clinical status of these patients. Are they hemodynamically stable, and how can you manage them? So for those heterotopic, either there's the option of saving the intrauterine pregnancy, or we are sacrificing both the ectopic and the intrauterine. Where there's possibility of saving the intrauterine pregnancy, I'm sure the ectopic can then be managed either by the surgical method, that's your salpingectomy or salpingostom, depending on what's more feasible, while you're trying to preserve the intrauterine. But there's always that risk of even losing the intrauterine pregnancy. Most of the cases that we have managed, we have had one or two, we've had, I think I've picked maybe about 5 or so where we managed to salvage the pregnancy. But most of them, as soon as you've done the ectopic pregnancy, you then tend to lose the intrauterine, and you have also eventually having to do a DNC for the intrauterine on your heterotopic pregnancy. Then in terms of precaution following laparoscopy for a pregnancy of unknown location, like from my initial presentation where I was saying, like what I also said, we don't get to do lots of these laparoscopies because it's not yet that very popular in Bulawayo. So for the precautions, I'll just probably mention from literature, and then if there's anything extra to add, or if I just miss 1 or 2 points, just kindly assist and then kindly guide me as to how these things can be done. But I think number one, it depends on where you're doing your laparoscopy. Is it part of the diagnosis, or you're actually going into management? So for those that are going into diagnosis and it has not been localized, you are still going in with that risk of going to do a negative surgery. But I think it's actually carries, or it's actually better to have a negative laparoscopy finding than for those where people have been opened up and they've had a negative laparotomy for an ectopic pregnancy. So it's also about to do a proper visualization, looking at the suspected areas. Of course, number one is to look at the tubal ectopic pregnancies, and then also localizing in other possible areas. That's your ovarian ectopic. If a patient has got your previous season, you're looking at previous scar ectopic pregnancies that are there. Yeah, I don't know if there's more extra that I've missed there. And then for those that are going in for management where diagnosis is made, I'm sure that one becomes straightforward because it's just going in to manage in terms of if you are doing a self-injectomy or you are doing a sulcostomy, if it's ruptured, if it's not yet ruptured and you want to preserve the fallopian tube. Kindly assist if there are other areas that are also.
All right, I'll also add a few. I think number one will be, since we don't know where this pregnancy is, we need to be very cautious in terms of probably this is an intrauterine pregnancy. So you want to minimize the risk of a miscarriage of that intrauterine pregnancy as much as possible. So probably starting with the gas insufflation, you try to minimize, to use the minimum gas that you can for the procedure. Then also avoid as much as possible the use of an intrauterine manipulator, because this may actually then traumatize the pregnancy and may increase the risk of miscarriage. Thank you.
Felix, any comments? Dr. Chamunyonga. We want to hear you. And Chipo.
I've no comments. Thank you.
How come you have no comment? Grant.
Hi everybody. Apologies, my reception is very bad tonight. Thank you, Robert, for the presentation. I have no comment at the moment. If anything arises, I'll comment.
Okay, if you have no comment, Grant, what sort of anesthesia would you use in pregnancies where you don't know the location?
Okay, all right, I had muted again. So in terms of anesthesia, not sure if you're asking about whether it's general or regional anesthesia, but definitely I would go for general over regional anesthesia if that's the
drugs.
If that's the question.
No, the question is on the drugs.
What I would avoid are drugs like halothane. I definitely would avoid for maintenance. So probably I would go for the fluorines. In terms of induction, I guess it just depends on the status of the patient, whether the patient is a candidate for using propofol, etomidate, and ketamine, and so on. It really depends on the hemodynamic status. But for maintenance, I would definitely avoid halothane because of its relaxing properties on the uterus, and probably would then maintain with isoflurane or sevoflurane or similar drugs, but not halothane.
Oh, welcome, Dr. Bvuma.
Thank you. Sorry, I'm late.
Okay. I think we were waiting for Dr. Tarisai's comments. Dr. Marere.
Hello, Dr. Shava.
Yes.
Comment on the anesthesia.
Yes.
Okay. All right. Just been listening to what Grant has been saying. Probably it would rest on initially what the clinical state or the picture looks like for a patient. So if, for example, we think she's ruptured and she's unstable, then we'd go with the drugs that are sort of like easy on the cardiac. I think the etomidate and things. I'm not really a good anesthetist, but yeah, I think I've heard them talking about those ones. something that can maintain sort of like a good blood pressure throughout without really affecting the rest of the system. Because if, for example, she's got a viable intrauterine, we are trying as much as possible to be conservative so that that pregnancy can be ongoing. So I actually, as I was thinking about how to answer you, was thinking if there is actually a role, or in fact, at the laparoscopy, I was just going to add that would also avoid removing cysts. Sometimes you find that there's a corpus luteum cyst that could actually be supporting a very early pregnancy, and the risk, the temptation sometimes is to remove things. So best to avoid touching those cysts, because that's what could be supporting the pregnancy. Avoid overhandling the uterus. So my question or slash comment was, would there be in any added benefit to give drugs like progesterone after these procedures if we think that she's got an intrauterine pregnancy to support it? Is there any evidence for it anyway, or there's absolutely no rule?
Robert.
Thank you. Yes, I want to comment. I'm actually also not sure as to should we then do a luteal support for a pregnancy, especially a pregnancy of unknown location. But like what you said, 90% of these pregnancies, a diagnosis is going to be made, except for those, the certain 10%. So after having done laparoscopy, to then support with progesterone for a patient who has no indication for progesterone support, I don't think I would want to do that, except for those that I've got evidence that need progesterone support, especially those with luteal phase defects. But otherwise, the rest, I don't think I would really want to give progestogens because there's no specific or direct indications. I'm not sure what others would comment on that.
Any other comments?
Hello.
Yes, Dr. Buma.
No, I'm sorry, I'm not sure what everyone is talking about. But I just always, just anecdotally, I think the reproductive health people, they just tend to use, especially in the first trimester, they always tend to use progesterone support mainly for the IVF patients or patients at high risk. They always give progesterone either vaginally or orally, progesterone or cyclogest, 200 milligrams twice a day. That's all I can say. I'm not sure what the original thing, but I routinely use it as well, based on the advice of the reproductive health guys.
But I think on the reproductive side, yes. Here I was looking particularly in management of this pregnancy of unknown location. Like we're saying, we've got a pregnancy of unknown location, and then maybe we've done a laparoscopy to localize the pregnancy, and then it's found to be intrauterine, or maybe we've got a heterotopic pregnancy where we want to salvage the other pregnancy, and then the ectopic one is managed. That's where I was commenting on. But if you say we should also support, I think I'll take that. I had not come across the literature on it, so that's what I was commenting on.
Very interesting topic, Robert. I think it looks like we have run out of comments and questions, and I think we can close the meeting.
Okay, thank you. Hopefully my presentation was not too short, so that's it's
no,
ended
it
up
was
very premature.
No, this was wonderful. No, this was wonderful.
Maybe just a general comment where I'll just ask other colleagues on management of this pregnancy of unknown location. Do we really where we come across them. I think most of my pregnant location, most of us have only used the serum progesterone, and here and there, we have used the beta HCG, and then here and there maybe the serum progesterone. Do we get to use these other models that we see in literature, like this M6 model or this scoring system? Is there any places where they are being used, maybe just for interest sake, to know if anyone is using the other scoring system or the risk stratification system, or most of us will then end on using the biomarkers only in the imaging modalities? Is there anyone commenting, or we are all using the serum progesterone and the beta HCG?
Yes, I was saying
The
that.
other one
Yeah.
is basically literature.
Yes, I'm not sure about the other stuff that you think, but I normally use those two.
The other ones that I commented on was there's what's called the Bernard scoring system, where you risk classify your patient by age. Let me just go to it for the, like this. Here it is. This one, the Bernard risk scoring system, where they are looking at giving scores. For extremes of age, you are given a score of 1, that's below 18 and above 38. Then in between the 20 to 25, you are given a -1, and then 25 to 38, you are given a score of 0. Your prior ectopic, you are given a score of 2, previous ectopic score of 3. If your patient is bleeding, score of 4. Then if you've had a prior miscarriage, you are given a score of -1. Beta HCG above 2000, score of -2, of -1, sorry, and then you are scored into a low risk and intermediate risk. Intermediate is where you score 0 to 4, and then high risk is more than 5, depending on that scoring system. The other models that I also saw is this logistic regression models, the M4 model, where these ones, they actually use the beta HCG value, and then they enter it into a calculator model. Or the M6, which is a 2-step. You start by doing a serum beta HCG. If it's below -2, then you are classified as a low risk. Then above 2, that's when you are then entered. You then do a beta HCG. If your beta HCG has got rising levels, then you are put into a scoring system, and then that scoring would then predict you have got a higher risk of an intrauterine or an ectopic pregnancy, or a pregnancy of unknown location. Yeah, I thought maybe Dr. Vuma, you'd actually assist on this, because you're the one who taught us not taught us per se, but you sort of make us more familiar with the IOTA scoring system and the other scoring system. I thought maybe these scoring systems are actually being used that side.
No. Thank you. I'm not aware of this. I'm also hearing it for the first time. Thank you. Yeah.